Good morning, everyone. Welcome all of you joining the public presentation organized by the Occupational Health Center. Today, we are so pleased to have, speakers from different provinces to coming to present for us. The topic is quite important right now in this time of the year, talking about masking in healthcare. We are going to have Dr. Kevin Hedges. He is an occupational hygienist from Occupational Health Center for Ontario Workers. And the second speaker is Dr. Joe Vipond, emergency physician, Rockyview General Hospital in Alberta. And the last one is Dr. Kraut, the physician of the Occupational Health Center in Manitoba. To begin the session, we would like to acknowledge that we are presenting this session on Treaty 1 territory, the traditional territory of the Anishinaabe, Greek, OG Greek, Dakotas, and Diné peoples, and the homelands of Native nations. The Occupational Health Center here acknowledges that we are all treaty people, and we recognize the history and impact of colonization on Indigenous peoples. We commit ourselves to active accountability, justice, equality, and reconciliation. To participate in this session, you can see this is a new function is come up that you could use the co-captioning function is available. Then you could just show captions. And to ask question, the Q&A session will be way to the last. Please put your question on the chat box area, then the presenter will answer it at the Q&A. This event is being recorded, so you could review the session and share. We are going to share on the social media and on our website. The session here is for 9:30 to 11 a.m. So not quite sure we'll be able to cover all the questions in the Q&A. If not, please connect with us. We cannot do that. That would be nice. So for some of the folks, welcome some of the folks, joining from different provinces, not only Manitoba. I know that quite a lot of people from Ontario and Alberta or the other province joining us. So just want to give you the quick, introduction about Occupational Health Center. We are the community health center funded by the Winnipeg Regional Health Authorities. We are now located on 167 Sherbrooke Street, Winnipeg, Manitoba, the same building with the clinic and the community health center. We provided the services to the Manitoba workers with work-related health issues that work closely with the Joint Workplace Health and Safety Committee for training. All our services is free, and please visit also our website for more information and resources. So the first speaker I'm going to introduce is Dr. Kevin Hedges. So he is going to do the presentation, focuses on about the respiratory protective equipment for all healthcare workers during the pandemic and beyond. A risk-based approach using Canadian standard, the CSA 94.4, using control banding. Dr. Hedges has 30 years of experiences as an occupational hygienist. He has been employed with the Occupational Health Clinics for Ontario Workers in Kraut as an occupational hygienist since 2016. Dr. Hedges is also the international past president of Workplace Health Without Borders in a volunteer capacity and the current board member with the same organization. He's also helped establish the Canadian aerosol transmission coalitions as a volunteer as well. Now, please join me to welcome Dr. Hedges.
Thank you very much, Tiffany, and hope everybody can see my screen there. How does that look? That looks okay? So I've been asked to talk about masking in healthcare. It's something very close to me. The Occupational Health Clinics for Ontario Workers were very concerned after the start of the pandemic, not long after the pandemic started. There was kind of like a downgrading of respiratory protective equipment, and there was just a really poor understanding around aerosol transmission. But just before I move forward, you know, we all need clean air, and we all need, you know, to not be exposed to anything hazardous in the air. So I've just got a picture there of a colleague's granddaughter with her nose over an air purifier. And if you think about drinking clean water, we all need to breathe clean air, the same as breathing clean water, drinking clean water. I just want to put out a special acknowledgement to Dr. Simon Smith, who leads the Canadian Standards 94.4 working groups, and some of his slides are his. So just if Simon's on the call, thanks, Simon. I am professionally employed with the Occupational Health Clinics for Ontario workers. I also do a lot of volunteer work with Workplace Health Without Borders, and we're actually going to be delivering a webinar tomorrow morning at 7 o'clock. It's an international webinar on asbestos, so it's open to the public, no cost, and if you want to learn about asbestos, then please chime in and join Workplace Health Without Borders. You can go through our website and find out about it. Through WHWB, we've had lots of speakers present, and I just put just a screenshot there of a presentation from Lisa Brosu, Dr. Lisa Brosu from the US, who knows so much on respiratory protection and how COVID is transmitted in the air, and she just provided a really good presentation all the way back in June 25th, 2020. We all knew it was airborne then, but she just provided good evidence through a presentation. You know, I'm just really grateful to be part of a team led by Alec Farquhar and Stefan Belladou, who's been the chair of the Canadian Aerosol Transmission Coalition, and Dorothy Wigmore's on the line too. So we're a group of scientists, and we're very concerned about misinformation after the pandemic started. You know, the COVID isn't airborne, but it is airborne. So I just want to make sure that that's reinforced very strongly. We did provide through the coalition Mask Smart 1, Mask Smart 2, Mask Smart 3, so you can actually get a bit more information about proper masking, and we try to cover off the public in the presentations as well. You know, the Occupational Health Clinics for Ontario workers, we just seem to provide so many webinars in this area as well, and we also share a lot of guidance material. We also had Lisa Brosu present through OCAV as well, so you can actually watch the recording there. We also have a fact sheet and the rationale for fitted face piece filtering respirators versus masks, so you can actually go there and download that fact sheet. There's a lot of information here, but there's a group led by Trish Greenhalgh out of United Kingdom, Oxford University, that's been putting the evidence forward around, you know, the airborne nature of COVID. And, you know, there's been two camps, and I think now most people do understand the importance of aerosol transmission. But there's been a lot of work by a lot of dedicated people, including Joe Vipond, who's going to speak later as well. But just they're the reasons, you know, from super spreading of events, transmission between people in adjacent rooms that don't come in close contact with each other, asymptomatic or pre-symptomatic spreads. At least it's likely to account for at least a third and perhaps up to 59% of all transmission globally, which makes it really difficult, doesn't it? Transmission of SARS-CoV-2 is higher indoors than outdoors. Nosocomial infections have been documented in healthcare organizations. It's a really important point that we can probably touch on in a minute. You know, and there have been strict contact and droplet precautions and use of personal protective equipment designed to protect against droplet, but not aerosol exposure, which is a concern. You know, viable SARS-CoV-2 has been detected in the air. It's been identified in air filters and building ducts in hospitals. studies involving caged animals that don't come in close contact, but they kind of join. The cages are joined with a pipe, so you can demonstrate that the SARS is actually passing from one cage to another through the pipe. But there's been no study disputing the evidence of airborne SARS-CoV-2 transmission, but there's limited evidence to support other dominant routes of transmission, droplet or fomal. Tomorrow is actually the National Indigenous Day, and I kind of found out about Dr. Peter Bryce, about a year ago. So he actually was responsible for the health of Indigenous children in schools. And he did some work to show that poor ventilation, along with poor, standards of care, was a primary cause of death. But he did mention from tuberculosis, that is, and he actually produced a report in 1907, and the story of a national crime, 1922, found that roughly 1/4 of all Aboriginal children attending residential schools died of tuberculosis. And even then, he was talking about the importance of ventilation. He was actually forced out of his position. They called him a whistleblower. And if you go and look at his grave in Beechwood Cemetery, he's got this modest grave in the background, behind a lot of dignitaries. But the Indigenous people, they do actually acknowledge what a great person he was. And also the John Snow memorandum, I won't read it out there, but there's a very good hyperlink to a video that talks about the virus being airborne. And we do really need a vaccine plus strategy, including proper respiratory protective equipment and ventilation as well. There's just been a new non-infectious air delivery rates for reducing exposure to airborne respiratory infectious diseases. That's a mouthful, isn't it? Released by ASHRAE, air conditioning organization in the US, and a lot of the standards around the world follow ASHRAE. But what this standard is asking for is much better, better airflow, or more air changes per hour than what's been in the past to reduce the risk from the transmission of infectious diseases. I believe the standards due to be released in summer, probably July. But it's not only healthcare, just this report showing that the outbreaks in schools and industrial settings, correctional facilities, obviously the tragedy with long-term care facilities as well. But it's really across the board here. And this is something that was just released by a guy called David Michaels, who actually headed up OSHA in the US for some time. And he's produced a couple of really good books. One's Doubt is Their Product, and the other one's Tragedy of Doubt. So he talks about scientists being employed by big companies to basically debate and challenge the evidence. So things take a long time to change because it's in the best interest of these companies if they don't have to follow certain guidelines. But anyway, he's talked about COVID-19 as an occupational disease that sickened and killed countless workers in healthcare and long-term care and in meat processing, agriculture, warehousing, transportation, corrections, and other essential industries. Nonetheless, COVID has rarely been treated or tracked as an occupational disease by public health agencies. So the lessons from the failure to protect workers during the COVID-19 pandemic can be helpful as the nation anticipates and prepares for the next public health emergency. This is just something that's current, and maybe Dr. Joe Vipond might talk a bit more about this. And we were talking recently about the mask mandate being dropped in Alberta on Monday. If you think about the number of patients that actually get COVID in hospital, they go in the hospital for something else and they end up getting COVID through nosocomial infection, hospital-acquired infection. And, really it's important that we think about all the different levels of protection, including respiratory protection, and just to drop the mask mandate just doesn't seem like good sense to me. Okay, so just the occupational safety equipment usage coverage, we have regulations and approvals, and, we have performance standards, and we have selection use of respirators. Following health and safety regulations ensures provision of high capability protective equipment to the workforce. Infection control guidance should recognize this. And the standard that I'm involved with, I'm on one of the working groups with Dr. Smith on selection, use and care of respirators, the bioaerosol working group. That's actually the standard for selection, and there is a new standard that prescribes the filtering requirements that's just been released. And once again, infection control guidance should recognize these standards. Now, I want to kind of talk a bit about control banding, which is actually in the standard. So control banding is especially important when there is no occupational exposure limit. So if you think about lead and cadmium and, silica, there are exposure limits. But for SARS-CoV-2, there isn't. But what there is a risk level. So the risk level can be used in the control banding approach. And in some situations where the ventilation isn't good enough, we may need better respiratory protection to equipment such as powered air purifying respirators. So this is how the control banding approach works. You have this kind of like gradient from lower risk to high risk, and then basically you just band the risk depending on the likelihood of exposure and also the severity. And with the Canadian standard, what we do is we have these risk groups that I talked about. So SARS-CoV-2 is risk group 3, agents that are associated with serious or lethal human disease or adverse health effect for which prevention or therapeutic interventions may be available. And then high individual risk, but lower community risk. So it's still a risk group 3 even now. And then, so that's part of the approach to the control banding tool. We need to look at the generation rate. So, is the patient coughing or sneezing, or is the person got their mouth covered, or is there an aerosol generating procedure? That kind of gets fed into the tool as well. And then the good thing about the standard is it actually integrates ventilation. So obviously where ventilation is very low, the risk is higher because the transmission risk is higher, and therefore you may need a better grade of respirator. This is the wheel. Basically, you can go through this yourself. You can actually figure out what each of the different inputs are. And I've just used an example here, just provided some inputs, which is asking for a level 2 protection here, which is a sign protection factor required at 25 or greater. So it's requiring a powered air purifying respirator. But a lot of the work is actually being made easier now because there is this online tool. Nevertheless, the tool is required for a qualified person. So, an occupational hygienist or someone's kind of who knows a lot about the standard. So there's still some kind of qualification or experience needed to use the tool. Okay. The kind of alarming thing is this is a Canadian standard, and it's really only required federally regulated workplaces in Manitoba, and parts of the standard around, including the requirement for fit testing, are only adopted in other provinces. So this isn't universally accepted across all of Canada. But it does actually, like I said, it has the control banding method in it, and it does take a lot of the guesswork out of figuring out what kind of respirator to give workers. But elastomeric respirators may be better in many situations. They may fit, they have a better fit, they may be more comfortable, and there also needs to be room for innovation. And I've just put you see the bottom powered air purifier respirator. There's a company that actually provides these, and they're not as burdensome as the big hood that goes over the head. But the powered air purifier and respirators offer a much higher level of protection than the half face negative pressure type respirators. But it's really important that hospitals engage with a coordinator. I don't know if there are many occupational hygienists employed by hospitals. Hopefully, hospitals will employ more occupational hygienists with the lessons learned. And I think we also need to think that the future will not be the same as the past. We need to understand how respiratory protection works, how it protects the user, including the proper selection, protection, providing comfort and fit should be a life skill. Think about all hospital workers should really have this training, and really all hospital workers should be fit tested, and they should be part of a program, and there should be several models available because different respirators fit different sized faces. And I just wanted to put these slides up here, this slide up here as well. And I just want to pay my respects to Dr. Joe Vipond. He was working in emergency till 1 o'clock this morning, and he's still getting up to talk to you about, this work as well. So there's a couple of pieces here that are put together by Dr. Vipond. And we know that, in occupational hygiene field and others, that a surgical mask is not a respirator. The only way to protect ourselves from something that's airborne is through a respirator. And this is just an infographic from OCAB, my employer, and it just shows the different levels of protection for respirators. So a surgical mask will not offer the same level of protection as a respirator. I just want to make that very clear. That's my presentation. Thanks everyone.
Thank you, Kevin. So the next presenter, we will have Dr. Joe Vipond. He is the emergency physician at the Rockyview General Hospital in Alberta. So his presentation will be focuses on about saving the world with the right personal protective equipment. Dr. Vipond has worked as an emergency physician for over 20 years and currently at the Rockyview General Hospital. And he is the clinical assistant professor at the University of Calgary. He is the past president of the national charity Canadian Association of Physicians for the Environment. He is also the co-founder and the board member of the local nonprofit, the Calgary Climate Hub. And during the COVID pandemic, he's also the co-founder of the Mask for Canada and the Protect Our Province, Alberta. Let's please join me to welcome Dr. Vipond.
All right. Well, thanks so much, Tiffany. And Kevin, what a great presentation. I think there's going to be a bit of overlap with what I'm presenting, but great, because that just means we reinforce the truth, right? And really, when it comes to bona fides, I don't have any, aside from the fact that I have a lot of outrage and sadness as to how the pandemic was managed. And maybe I'll even start by saying, like, we've lost. We've lost. We never had our hospitals acknowledge airborne transmission. We still have contact droplet precautions when I go into places. They still believe that surgical masks are PPE. And I'm a little less optimistic than Kevin that the future is not the past. I'm worried that the future is going to be worse than the past, because that seems to be where we're at. The only thing I see where there's been positive moves is on ventilation and ASHRAE's guidance. I do feel like institutions and building managers are taking this more seriously in some places, but not in schools, not in Alberta schools. Anyways, that's my start. I'll share my screen now and we'll go into the presentation. Yeah, we've lost so badly at the moment that that yesterday we lost universal masking in the emerge. I'm hoping that, or in all our facilities, I'm hoping that this will end up being a conversation at the end that we can discuss why some people think that's appropriate. Some people may think that's inappropriate, because really my whole presentation is very similar to Kevin. Kevin's even one step further, right? Kevin's like, well, we need to go to elastomeric masks because it's the best thing out there. And I'm going to be talking about, well, we need to go to, at least do good airborne protections with respirator style masks, disposable even. But the reality is the kind of crappy surgical masks that we've been using aren't even available. So the Overton window has shifted so much that I feel like Kevin and I are talking all the way over here and the rest of the world is all the way over here. And I don't even think we can come into the middle somewhere. But I guess that's why we're talking. So saving the world with the right PPE. This is basically a talk I was asked to do at the IPAC conference in Vancouver last month. And so I thought it'd be a good opportunity to repurpose it for this. One of my other hats that I wear is as past president of the Canadian Association of Physicians for the Environment, because not only do I care about worker and patient health, I care a lot about our climate's health and the world's health. And so I think we do need to be thinking about how to make good environmental decisions when we're making good policy decisions. And that can go right with the PPE. So I have no conflicts of interests related to masks at all. I've gotten a couple of free masks for trying them out, and that's about it. It's probably $80 worth of value there. So I want everybody to put on their thinking hats. This is the interactive part of today's sessions. I want you to think about what would make the most impact on a hospital's GHG footprint. What change in masking use? So these are 5 options: switching to plant-based mask filters, switching to elastomeric respirators from disposables, using a respirator-style mask instead of a surgical mask for an airborne virus, using as few masks as possible, or sourcing masks from a local manufacturer. As you know, most of our masks come from overseas. So you guys think about that. I'm going to give you this is our 7th inning stretch. I think the correct answer is C. I'm sure we could have a debate on this, but I think actually using the appropriate style PPE for this type of transmission would be the most important thing. And I'm going to walk you through my reasoning. You can tell me whether I'm full of it. So we're going to talk about Bob. Bob is a 72-year-old male in a hospital for a hip replacement. He's a retired firefighter. He wants to be more mobile so he can continue hiking with his 3 children and his 8 grandchildren. So I know that Kevin has gone over some of this. We're going to talk a little bit more about why choice of PPE matters. So there's 4 truths, and I think these are all true. I think there's evidence for everything. I'm not going to go through all that evidence, but COVID is airborne. It's a predominantly airborne transmitted disease. At least 50% of infections come from asymptomatic patients. So people that are either pre-symptomatic or asymptomatic. Aerosols are generated by many activities, and that includes the simple activities of breathing and talking. And probably the most controversial one, COVID hospital-acquired infections are preventable. So post-op, Bob is sent to a 4-person room with curtains separating each patient. 2 of his roommates are also recovering from orthopedic surgery, awaiting placement in long-term care. One has dementia and is prone to wandering. So this is the exact same paper that Kevin presented in his first presentation. I'm not going to belabor it, but there are 10 very good reasons why we think COVID is airborne. And there are basically no evidence for contact droplet. And if people are curious, we can talk about why contact droplet became the paradigm in the Q&A afterwards. I think there's some very interesting discussion that can go along that. So Bob's roommate, Ralph, has a bunch of visitors over for an hour on post-op day 1. Ralph's 23-year-old daughter, Jennifer, is here 3 days after a wedding where, unbeknownst to her, she was exposed to COVID. So asymptomatic spread. In a lot of ways, this is one of the key difference between the 2003 SARS-CoV-1 outbreak and the SARS-CoV-2 outbreak, the more recent one. In SARS-CoV-1, pretty much you became able to transmit the disease once you had symptoms, once that sore throat, runny nose, cough occurred. And so therefore isolation was much easier because as soon as you had symptoms, please stay in your house. Please don't go out. But SARS-CoV-2, there's plenty of evidence that more than 50% of all infections actually come from people with no symptoms whatsoever. They either never get symptoms or they're pre-symptomatic and get symptoms the next day. And I think we've all heard of stories of people going to weddings, getting infected, and then 2 days later, somebody in the wedding party tests positive, and then everybody else tests positive. This is also poking at a little bit of dogma because we've been in our healthcare community reinforced that there's these things called aerosol generating behaviors, aerosol generating medical procedures. And these are things that were identified in the SARS-CoV-1 2003 outbreak that seem to be related to infection. It could be anything from intubation to BiPAP to nebulizing. And nobody ever really looked at the physics behind these AGMPs until recently. They just presumed that since these activities were associated with infection in hospital in that 2003 period, that therefore they were a higher risk. But because we know that coronaviruses are airborne transmitted, we can actually look at what activities create aerosols. There's this schematic up in the upper right corner here that shows how you really do good studies of what produces aerosols. And this is based on the paper down below here. And so they've done this for a bunch of activities. And I just wanted to point out that this is a logarithmic scale on the left side, which means it's quite a bit higher on this end. So, and the reality is the things that we have classically been taught as AGMPs actually produce less aerosols than regular activities like talking, exercising, shouting, forced expiration, and coughing. Living, breathing is an aerosolized generating behavior. And, it's no surprise that Seattle choir super spreading event that happened early on in the pandemic set off so many alarm bells because of all the activities that exist. Singing is the worst. But let's not neglect simple things like talking and coughing. So post-op day 3, scheduled to go home, Bob gets a fever, has a cough, and is increasingly weak. His PCR test is positive for COVID. He can no longer participate in any rehab activities and is essentially bedridden. I think especially with Omicron, what we're seeing is instead of having these big respiratory illnesses with cough and runny nose, we're seeing a lot of people that are just getting weak. I know in the Emerge, anybody who has an unexplained fall, I would test for COVID. And I would always be surprised that despite there's no other symptoms, just that act of falling would indicate that the person often has COVID and has to be admitted to the hospital because they're just so weak from this influenza-like illness. So I acknowledge that this is an old screen, but with our acute care outbreaks in Alberta. So this is in May. We're still having acute care outbreaks, and every single person who gets infected in a hospital, I think, is a tragedy, honestly. We seem to be okay making the effort for preventing C. diff, for TB. We don't seem to be caring that much about preventing COVID, and I don't really understand. Maybe it's because it's so hard to deal with requiring universal masking. But the reality is our patients deserve better. When they come in, they're weak, they're susceptible, and we're letting them get infected. And the other thing that's really important to note with this acute care outbreaks in Alberta, this page on the left, is that these are outbreaks that were occurring with at least surgical masks being mandatory in hospitals, and we lost that yesterday. So I can't imagine how, unless COVID magically disappears, how that will not result in worsening hospital-acquired infections. This graph on the bottom right is percent of hospitalized patients who got their COVID in hospital in the United Kingdom, actually in England. And you can see it's up around 28% as of a month ago. So 28% of all COVID in hospital came from a COVID that was acquired in hospital, which is incredibly sobering. And we don't have any reporting on this in BC. I don't know about Ontario, Kevin. I'd love to hear if that's the case. And Alan, I'd like to know what kind of reporting transparency is occurring in Manitoba. Thankfully, we still have transparency here in Alberta. But of course, we're only reporting on outbreaks. We're not reporting also on individual cases. Post-op day 12, recovered from COVID, recovered from surgery. Bob is finally sent home. It's 9 days later than expected, and he's well behind on his rehab schedule. So this slide is just to talk about the impact of COVID on a patient who gets it in hospital. Pre-Omicron, there were a number of studies that looked at case fatality rate, and it was incredibly high, 39 to 42% of CFR versus for somebody who was hospitalized with a community acquired, 26 to 35%. So over a 10% rise in the CFR. And I just want you to absorb that information, that around pre-Omicron, 40% of people who got COVID in hospital died. 4 out of 10, 2 out of 5. That's insane. And we never stepped up from contact droplet. We never said, this isn't right, we need to prevent this. We need to put in respirator masks. And I don't understand what's happening with infection protection and control when there's no evolution of thought. And if you are immunocompromised and you get a hospital-acquired infection, you have had a double risk of death. There was one study, there was one news report out of Ontario that said 5% of all deaths in Ontario, 5%, so one out of 20 of all deaths in Ontario came from a hospital-acquired infection. That is damning. That is, and we didn't change. So post-Omicron, it's a bit better. There's 2 studies that I've got here. One is 8.4% CFR. That's from November to April of last year. That's at this bottom one. This one here. And then the 10.6% that is at the bottom is from this report that was leaked to some of the activists in Australia. I believe it was Victoria. I could be wrong. But basically 10.6% CFR. That's that number right there. So other outcomes, presumably there's increased duration of hospital stay. Unfortunately, I don't have a comparison between somebody with a hip fracture and how much longer it would be if you were COVID versus non-COVID, but presumably it's longer. One study showed 27 days versus 16 days for non-hospital acquired COVID. So like if you were admitted for COVID from the emergency room from a community, you'd be 16 days. If you got it in hospital, it'd be 27 days. And a real significant risk of readmission. So 15% of all people who were sent home came back again in that first wave. So Becky, an RN on Bob's ward, gets COVID from caring for him. Now she has a significant risk of long COVID and therefore wishing the nursing staffing crisis. Anybody out there in internet land have a problem with hospital staffing? I think that's pretty universal. And there's good evidence to suggest that no small part of that is because of long COVID. Numbers like 4 million Americans being unable to work because of long COVID. This is really an under-recognized problem. And I think a little bit willfully, because nobody wants to deal with the fact that we have been told it's okay to get COVID, it's just a cold, and that still we have a significant risk of being disabled from this. Higher risk being female, higher risk being a healthcare worker or a teacher, and that's what Becky is. So 10.2% incidence in the Omicron era of long COVID. And I've already mentioned some of the other people that are at risk, as well as the higher severity of initial infection. There is increasing evidence that the more vaccination you have, the better. Maybe 6 months ago, I kind of got the feeling that your risk maxed out or minimized out at 3 shots. So 2 of the initial and then a booster, you probably maxed out. But we're maybe getting a bit of more information that every shot matters and that the higher number of shots you have, the lower risk you have. My sense is around 7% of people that are fully vaccinated and get COVID could get long COVID. And just to put it in perspective, 7% is 1 in 14, which is still really bad Russian roulette odds. So what does this have to do with greening healthcare? Well, hospitalizations cost money and energy and creates waste. So for around 4.5% of all of our 4.6% of all of our GHGs come from the healthcare sector. Every day of being in an acute care hospital causes solid waste and causes CO2 equivalents. And then, of course, there's the cost to society of disabling our staff and disabling our fellow citizens. So if you go from being bedridden, being unable to work, and you have to be cared for by society, what is there a cost in energy, dollars, and moral fortitude? And as I mentioned, this may be the controversial slide because I really get the sense from the people in power that they've kind of given up on preventing hospital-acquired infections, that they feel it's not worth the effort. But we know that there are 4 really important things we can do. Universal masking. That gives us a shared understanding of the problem and the expectations of everybody for everybody. Yesterday with our first day off, I had a lot of people going, I just heard in the background talking, I'm not really comfortable not wearing a mask. And I'm like, we don't have to not wear a mask. You're totally allowed to wear a mask. I'm like, yeah, but nobody else is. And it's like, these are these societal heuristics that we use. We do what everybody else is. Improved ventilation in hospitals. We need to have about 13 plus air changes per hour in all spaces. That's lower in lower risk areas, but we need to be thinking about this in schools and our other institutions. In those places with inadequate ventilation, we need to be adding filtration to those areas with HEPA filters or other portable filtration systems. And then we need to be considering using the proper PPE. I'm sure many people understand that surgical masks were never designed to be PPE. They're designed only to do 2 things. They're designed to keep you from spitting into a patient's wound, and they're designed to keep the patient from bleeding into your mouth. They're surgical procedure masks. That's why they're called surgical procedure masks. And if you actually look on the Occupational Health Hygienist website, you will not see them defined as PPE. Even the CDC doesn't define it as PPE. So these are my Contact information, you can follow me on Twitter. I'm still there, but maybe not for long. Our website is cape.ca. That's my email address at the bottom as well. Thanks, Tiffany. Back to you.
Thank you, Dr. Vipond. Very great information to share with us. So last but not least, we have Dr. Aaron Kraut. He is the physician of the MFL Occupational Health Center in Manitoba. He's going to be presenting to giving out the update on the risks of COVID in healthcare and the current COVID situation and the guidelines and the risk perspective change over time in Manitoba. Dr. Alan Kraut is an associate professor at the University of Manitoba in the departments of internal medicine and community health sciences. He has practiced clinical occupational medicine in Winnipeg, both at the Health Sciences Center and the Occupational Health Center. And he has been attending, he's also been an attending physician on the internal medicine clinical teaching units at the Health Sciences Center for 30 years. Dr. Kraut is also the medical director, Occupational Health, Winnipeg Regional Health Authority's integrated sites. So please join me to welcome Dr. Kraut.
Thank you, Tiffany. And I'd also like to thank my two previous speakers for giving very informative talks. I'm going to share my screen now. And can everyone see this okay?
Yes, really good.
Good. Okay, so let me just minimize this part here. All right, so I'm gonna talk a little bit, take a little bit different slant than the two previous speakers, and I'm going to talk a little bit about our current situation in Manitoba and what are we doing now in June 2023. I do have a variety of conflicts of interest. I have a position at the University of Manitoba. I have a position at Shared Health, which is an umbrella health organization for the province. I have a position at the WRHA. I also have positions at Health Sciences Center and St. Boniface Hospital and the MFL Occupational Health Center. For a number of years, I've done consulting for both labor and management and compensation board, so I'm quite involved in this. And the way I keep everything straight is I sort of try to tell everyone the same thing. Sometimes labor likes it, sometimes they don't, sometimes management likes it, sometimes they don't, but at least I'm trying to be consistent in what I'm saying. So Joe mentioned that yesterday in Alberta, they changed their requirements and dropped masking in healthcare. And we did that just about a month ago. And this is from the Shared Health document that they talk on effective May 10th. PPE requirements will be lifted in most areas in the Manitoba health system. They ask that healthcare workers get reacquainted with routine practices and additional precautions, including point of care risk assessments, respiratory hygiene, and that they select the appropriate PPE to prevent a variety of exposures. However, masks were maintained in certain populations, and this is like in cancer care where people were quite immunosuppressed. It also said for healthcare workers, for all healthcare workers, wearing a medical grade mask or eye protection is an option in any setting in care interaction. Masks and N95 respirators will continue to be available for you. And in addition, they ask people to do point of care risk assessments, and that's assessing their risk. So just for, I'm not sure how many people are in healthcare here in Manitoba, but we had a system of dividing things into orange, red, and green. Red are known cases of COVID, orange are suspect cases of COVID, green are people where we don't suspect cases of COVID or they recover. And then we do have a different standard for aerosol generating medical procedures. And I have to say, I share some of Joe's concerns regarding these, but this is still quite common. And I think in everywhere they use a higher standard for that. Now for orange and red, The current guidelines from Shared Health is that N95 respirators should be the default choice for respiratory protection, and that but healthcare workers can choose to use a procedure mask after a point of care risk assessment. We're told not to use them, and that we're told to use N95s for aerosol generating procedures. For green zone patients or green patients that where they're not suspected of having COVID, or they've deemed to be recovered, we're told to use routine precautions. Masks are now not required, but they're optional, and you can use either a surgical mask or an N95. And if you're doing an AGMP in a green type patient, you should do a point of care risk assessment to determine what you want to use. And again, as I mentioned before, higher areas, cancer care, the HIV clinic are still requiring masking. So a lot now is getting left to the individual healthcare worker to figure out what they want to do. And I think over time, I think with COVID, our perception of risk has changed, and I have a little bit different slant on this than maybe Joe did. But at the beginning, we were all very, very afraid of COVID. It was an unfamiliar exposure, and that is associated with a much higher perception of risk. As we've come a little bit more familiar with over time, some of our concerns have decreased a little. When we dropped masking in the community, people were wearing it more. Now it's dropped off a bit more, and now you still see some people wearing masks, but not very many in the general community. Our perception of risk is also affected by our concern about the outcomes. And at the beginning, COVID had many dreaded outcomes, and over time, it's dropped down a little bit. Certainly, the number of people who are hospitalized with COVID has fallen. There certainly still is some concern about long COVID, but I don't think people are overall as afraid of the disease as they were before. Whether that's warranted or not is another question, but I do think people aren't as concerned. Also, at the beginning, there were a lot of involuntary exposures, and that increased perception of risk, and that may have settled down a little bit over time. This perception of risk comes from the environmental literature, and certainly people who perceive benefits from exposures to things in the environment usually perceive the risk as less, while if you have no benefits, you see it as more risky and aren't willing to accept the higher risk. And sort of the reverse of this is something that I do think applies now with our dealing with COVID, is that there's the hardship hassle. And many of the healthcare workers I've talked to have said that they're all PPE'd out with this, and they were quite happy when the opportunity came to drop back. I think that people found them awkward to wear and had some difficulties with it. And because of that, they're now willing to accept a little bit more risk to get rid of that. So this is, I'm just going to present some slides now on COVID in Manitoba and other respiratory diseases. The green bar is the current cases. Now, one has to recognize that this is clearly an undercount, because right now we have a lot of people who aren't testing or are self-testing at home, and they don't get measured in the official statistics. And I'll come back to this green line in a little bit. The orange line here is for 2021, and the gray line is from 21-22. And please note that the scales are different. For 2021, 2022, the scale is about 20 times what it is for 2023, the green line. So if they were all done on the same scale, the green line would be like right at the bottom. We wouldn't be able to see anything. So we can see the number, and until this point, which is the peak of Omicron, we had reasonably good data, because pretty much all cases were PCR confirmed. We can see how many cases there were and the various waves. When Omicron hit, basically we stopped broad testing, and that probably is part of the reason why there's a steep fall here. And we're only testing in rare circumstances, only people are admitted to hospital or they present in emergency rooms or some, but that's fairly consistent. So now getting back to this green line, we do see that over time this year, sort of this is, one is January. So this is November, December falling down. The numbers have been falling a little bit over time, still some, but not zero here. Again, the age distribution of cases is heavily dependent on who's actually tested. And here we see that most of the cases that are currently diagnosed by PCR are in older people, females and males. This is a slide looking at the current testing volumes in the province and the percentage positivity. And again, we're sort of falling a little bit down, but we still have a fairly high percentage positivity, around 9%. Very early in COVID, that would have been quite alarming. It's fallen from almost 30% in last fall, but it's still, it's not zero, right? So there's still some COVID out there. This is a slide of our severe outcomes. Looking at deaths, hospital admissions, and ICU admissions. Now, these are for hospital admissions. All of these are people who have who haven't died or admitted because of COVID, but with COVID. And so some of there's a bit of controversy on what we should actually measure. If you just look at people who were admitted because of COVID, you might miss people who have sort of an inflammatory condition that led to them having a stroke or a heart attack or something like that, if you just count the respiratory admissions. If you admit people who had COVID in the last month, you're also including people who you know, had a car accident or something like that, which probably wasn't related to COVID, but they had COVID in the past. The true answer is probably somewhere between. However, looking at the data, though, our numbers are sort of falling down a little bit still. Okay, and this is till June 10th, which is about like 10 days ago now. This slide looks at weekly COVID outbreaks, 2021, 21, 22, and now in 22, 23. And again, the definition of outbreaks hasn't changed during the year, and they're coming down a little bit. And, you know, we changed the last month. And so far, we haven't seen an uptick in those, and maybe we will in a bit, but we haven't yet. And this last slide on sort of the level of disease looks at, you know, COVID isn't the only disease in town. Other diseases can be transmitted, other respiratory viruses are around. And this is the number of cases of RSV, influenza, and others that are seen. And you can see there was sort of a peak in the late fall, and that's coming down now. Very little RSV, very little influenza. So we have still some disease, probably a bit less than before. That's how I would summarize that. Now I'm going to present three epidemiologic studies that look at this mask issue and what we can do. And just so that we're all on the same page, I just want to spend a little time explaining what odds ratios, risk ratios, hazard ratios, because they all talk about them. Basically, they're comparing a group that are exposed to a group that are not exposed. And a ratio of 1 means that there's basically no difference between the two. When if the ratio was 2, it's that the exposed group has twice the rate of people who aren't exposed. And if it's 0.5, it's half the risk, basically. They also present 95% confidence intervals, and which is a range. And if the interpretation is that one's 95% confident, the true value is in that range. And generally, if one with a p-value of 0.05, if the confidence intervals include 1, the risk is not felt to be statistically significant. So it means it could be either a bit lower or higher if it includes 1. If it's all below 1, it means that there's a protective effect. If it's all above 1, it means that there's a detrimental effect. Okay, so the first study I want to talk about is a study published in Morbidity and Mortality Weekly Reports last year, and it looked at the effectiveness of face masks versus respirators in indoor public settings for prevention of COVID infections in California. And in their preamble, they talk about face masks or respirators effectively filter virus-sized particles in laboratory centers. The real-world effectiveness of face coverings to prevent acquisition of SARS-CoV-2 infection has not been widely studied. So basically what they did was they identified 652 COVID cases and compared them with just under two to one, over 1,100 matched COVID negative controls. All the people reported being self-reported being in indoor public settings during the 2 weeks prior to their testing, and they reported no contact with anyone confirmed or suspected of having COVID infection during that time. So the thinking is that if they got it, they may have got it from an indoor exposure. And what did they find? Well, they asked people about their masks. The cloth masks lowered the risk 56%, surgical masks 66%, and respirators lowered at 83%. The actual statistics, though, showed that a cloth mask, although it lowered it, it wasn't statistically significant. So they didn't think the cloth mask protected. Both surgical masks and N95 masks were shown to be protective. The N95, KN95 respirator was shown to be a bit more protective, although the confidence intervals overlapped, so they couldn't say that surgical N95s were better than surgical masks in this setting. We don't know whether the N95s were fit tested or not. We also don't know whether the people who wore the N95s did other things that might have lowered their risk. But certainly there's some evidence that they're certainly more protective, which would be consistent with what the other speakers were saying, although the extent might not be as great as was previously mentioned. The next study I want to talk about is study coming, Nico Cherry in Alberta led this. And it talks, and this is a Canadian study looking at the risk of COVID-19 infection in Canadian healthcare workers in relation to vaccination, and they did a nested case control study. So they had a cohort of over 4,300 healthcare workers involved in direct patient care in Alberta, Ontario, BC, and Quebec. And so they followed them. They identified 533 cases of COVID confirmed by PCR. They matched them to just over 3 to 1 by province, gender, and date of vaccination. They completed a questionnaire exposures, reporting exposures experienced in 21 days before the case date. They recruited from October 20th to March 22. And we have to remember the vaccination became available in December 2020. And they limited some analysis to people who, for whom the COVID transmission in the community seemed unlikely. So first of all, they found that people were unvaccinated, and the unvaccinated group includes people who they couldn't get vaccinated before the vaccine came out, and also some people who didn't want to get vaccinated, although they said that there weren't many of those. But you can see that if they had contact with an infected family member, they were almost 12 times as likely to get COVID. And after vaccination, that fell by half to around 5 times. So still a risk, but not as high. For occupational factors, they found in the unvaccinated group, they found that working with COVID-19 patients on a designated ward and working with objects used by the patients were all statistically significantly associated with elevated risks of COVID between 2 to almost 5 times. When vaccination came in, those risks fell to under 1. So they were no longer associated with an increased risk. What they did find, though, was, and I'm not familiar with all the ability to access N95s in Alberta, but my understanding is, and maybe Joe can correct me if I'm wrong, is that although they weren't required, they were similar to us. They said they should be used, but people had the option of not using them. When there were few people who said that they were not able to access N95s, but amongst those people, the risk of getting COVID was still elevated. And we didn't do this in Manitoba, but in some places they reused and sterilized N95s. And again, that was associated with an increased risk, probably because you couldn't fit test with the used N95. So that was something we never did here. But certainly vaccination led to an improvement. You know, in our own cases, the first wave here, where we had an outbreak on H4 at Health Sciences Center, about 30% of the people in the province who had COVID were healthcare workers working on that ward. The second wave, we still observed an increased rate. And by the third wave, with the start of vaccination, our rates in healthcare workers really fell. There was a bit of an uptick as some of the vaccine, you know, the effectiveness of the vaccine wore off over time, and now we're recommending more dosages. So the conclusions of these authors were these results suggest that after a rocky start, the risk of COVID-19 infection from work and healthcare is now largely contained in Canada, but they did suggest the need for continued vigilance, and they mentioned the concerns about N95s and reusing N95s. So the third study I want to talk about was recently published, and it was a study looking at medical mask versus N95s for preventing COVID-19 among healthcare workers at a randomized trial. And the arguments for N95s have been well presented by the previous two speakers, and I'm not going to repeat what they said here. The medical mask side, people would argue saying that, you know, the epidemiology that looks at healthcare workers, really there's all sorts of biases that's saying that N95s work. You know, the study I presented, they say, well, we don't know if the people who wore N95s, maybe they're doing other things or lowering their risks in other ways. Also, a lot of the experimental studies aren't sort of real world, and we need a real world experience to determine the difference here. And as you may know, the WHO says that you can wear procedure masks or N95 respirators, and CDC says you can should wear N95s. So what do they find? So this was started in Canada, and they looked at unvaccinated healthcare workers, which was one of the criteria. When it spread to other countries, they included healthcare workers that were vaccinated with not the mRNA vaccines, but with vaccines that were less effective. So they randomized people to wear medical masks or N95 respirators. They were allowed to wear an N95 respirators for AGMP procedures or in other situations where they felt it was appropriate. And they followed people for 10 weeks. And their outcome measure was PCR confirmed COVID-19 infection. So what did they find? Well, they found that the medical mask and the N95s, there was really no difference. There was no protective effect of wearing N95s, which is a bit concerning, I'm sure, to the previous speakers, because we think that N95 should be better. But I think you have to look a little bit deeper at that and sort of actually look at the raw data. So if you look at Canada, where like we all live, right, the medical mask rate was 6% versus the N95 respirator rate was 2%. In Egypt, about a quarter of the people came in Canada. The biggest contrast was in Egypt, where about 50% of the people came, and there really was no difference between the two. The next slide presents the hazard ratios. And again, in Canada, the ratio was 2.83, ranging from 0.075 to 10. So there was clearly a difference between Canada and the overall rate, and certainly a major difference between Canada and Egypt, where in Egypt, there was really no differences. It was like at 1. I think it's important to really, before we say that N95s aren't more protective, we have to delve a little bit deeper in this and look at comparisons between the countries. Canada, Pakistan, and Israel was all pre-COVID. Egypt was more pre-Omicron, sorry. In Egypt, it was more after Omicron. So again, that's part of the difference. I mean, we live in Canada, so we think maybe the results are more important for us now, although this was, you know, the data is from pre-Omicron and pre-vaccine, so maybe the playing field has changed. We should look at what Egypt is. Egypt is after Omicron, but with poor vaccines. So maybe that has more to say to us. But the other important difference between them, if you compare Canada, this is the exposure time to patients who provided, of the healthcare workers providing care to patients who had COVID. They averaged about an hour, while in Egypt it was about 7 hours. So clearly they had, in Egypt, there was much more exposure to patients. And also in community exposures, this is events per 1,000 days in Canada, it was around 10. They're similar to the medical mask, the N95. In Egypt, they were 4 or 5 times that. Now, in the paper, they mentioned trying to control this, but it's clear to me that in Egypt, the healthcare workers there had a much higher exposure to COVID than we had in Canada. And, you know, one of the reviews mentioned, when we talked about this paper, they said that in Egypt, they weren't really wearing masks in the community. And then they certainly had much higher exposures. And I think of that as sort of the analogy that if you have to walk 10 blocks in a thunderstorm and you have an umbrella and it's protecting you for the first 2 blocks, and then the umbrella breaks and you don't have an umbrella anymore and you have to walk 8 more blocks in the pouring rain, well, you're probably just as wet at the end of the 10 block walk if you had the umbrella and you didn't have the umbrella. But that doesn't mean the umbrella didn't protect you. So I think we have to be a little bit careful in using this study to show that N95s aren't protected, but I'm sure this study is going to be mentioned repeatedly when this discussion comes up again. So I want to just share this with everyone who's participating. So, you know, this is again, the information I'm presenting. And also I have no logos on my slides because this is what sort of I think and doesn't necessarily represent any of the organizations that I work with. But that I think we have to realize the risk to healthcare workers for COVID infection is a combination of their occupational and non-occupational risk. I do think that employers have a responsibility to have a safe workplace, and we have to try to lower the occupational risk as much as possible. I think our local experience, so when sort of asked our nurses when we were still able to collect data, seemed that after vaccination, most of the people who got COVID and healthcare workers were reporting exposures away from work and not at work. And so I would sort of agree with what came out of the Alberta paper, that our post-vaccination PPE protocols are generally working well. Obviously, things can happen and they have to be tweaked. I agree with the other 2 speakers that there's sort of there's no force field at 6 feet, which prevents transmission, and certainly there is a continuum after that. And my own view in all of these respiratory viruses is that the distance is a correlate of exposure, but another important factor is the infectivity of the specific organism, and certainly that makes it, if it's very infective, then when we spread out further than very close to someone's much more likely to get it. I also agree that masking lowers the risk of acquiring COVID, and that I think that N95s are probably still better than medical masks, but medical masks do give some benefit here. So what to do now in June in Manitoba? Well, I think that for infected or suspected COVID patients, really, although the guidelines say that N95s are the default respirator, they really should be used because I think they provide better protection. And as per other IPNC protocols, you're still supposed to use eye protection, gloves, and gowns. Well, I guess this is the issue of now what to do when COVID's not suspected. And there's a number of things to do here. One can sort of stop wearing masks. We're a month out. I work in a number of scenarios. One is in the occupational health clinic. We're next to Clinic with a K, which is a community health center. When I walk around there, like nobody's wearing masks at all. I took a trip through our emergency room at Health Sciences Center, which is our major teaching hospital here, and spoke to the staff there. And about a quarter to a third of them were still wearing masks. Higher amongst the healthcare aides than amongst doctors and nurses. I should mention that healthcare aides at the beginning of COVID had more serious outcome. More of our serious outcomes than healthcare workers were in healthcare aides. It's not clear whether they got it from work or not, or they had other issues, but certainly they were a group over affected. And they're also a group that spend the most time with patients. So more of them seem to still be wearing masks. The other option is to continue wearing masks. And certainly there are some people doing that. You don't have to not wear a mask, and you can wear an N95 or a surgical mask in our guidelines. And I think some people who are particularly concerned with COVID or may have underlying health conditions are probably make up the most of the people that are still wearing masks. Next group is people who might say, well, I'm going to continue wearing a mask, but stop wearing it when certain criteria are met. The issue with this approach is that it's really not clear what criteria one's going to use to say that this is why we should stop wearing masks. We do have respiratory viruses throughout the year. And the final one is to try to come up with a selective use of masks when one deems that the risk might be higher. So what might be some of the reasons to do that? Well, the first is clearly you have to consider your own personal level of risk. Someone who's immunosuppressed, for a variety of reasons, will likely want to continue wearing a mask to protect them. Again, if you live with people who are immunosuppressed, or you work in an area where there's a lot of immunosuppressed patients, again, people might be more concerned about wearing a mask to protect them or others, as Joe has mentioned. I think another major criteria here to decide what to do is the level of disease in the community. I have mentioned that it seems that the level's going down now, but it hasn't disappeared. I think this is going to be an issue when the fall comes and our disease in the community comes up, whether that's COVID or other respiratory viruses, and whether there should be a discussion about bringing back masking in healthcare facilities, but that's another issue, another time. I think something that really influences someone's decision if they're not actually around sick people who they suspect having COVID is what's your own level of concern of the disease. And that will certainly influence some people to be more likely to wear masks. I think another criteria here is what are you actually doing in the community? If you're going to restaurants and shopping centers and concerts and you feel comfortable not wearing a mask, then most of those people likely not be comfortable, will be comfortable not wearing a mask in healthcare now. Another criteria that people look at is, this hassle factor of wearing the mask. How bothered were you by the mask? And some people, healthcare workers, feel it affects their ability to communicate and relate to patients. So that might be another reason why they'd be less likely to go on wearing a mask. And the final thing is where do you work? Is an enclosed place with poor ventilation? You might be more inclined to want to wear a mask. Also, the number of people you may have in contact with, you might be inclined to wear a mask. I just want to end with this, with the hierarchy of control, and I think that's very important. And I think we all recognize that PPE are seen as the least effective measure of control. Elimination, I think, is going to be hard for us to do, and maybe the virus will substitute itself and become less serious or cause less adverse health outcomes. Engineering controls, though, is something that we can look at, and I think it's very important to try to improve the ventilation in all the areas we work in, both healthcare and away from healthcare. Administrative controls like vaccination, I think vaccination is extremely important. We're waiting now on which vaccine will be made available. I see the FDA in the States recently approved or recommended a single variant vaccine, so the XBB, which apparently is the one circulating in the States. So it's not going to be a bivalent vaccine. It's what they're recommending. CDC and NACI still haven't come out of their recommendations of exactly who should get it. My sense is that they'll probably recommend it for at least at a minimum for high-risk people and people working with high-risk people, which would be include healthcare workers. And I would strongly encourage all healthcare workers to be vaccinated with and bring their vaccines up to date. And the final one is the PPE that we've talked about. So I'd like to thank you all for listening. I know I think we all went a little longer than we thought, so there's not that much time for questions, but I'll pass it back to Tiffany, and I'll stop sharing my screen now.
Thank you, Dr. Kraut. I know, there's a lot of information sharing and conversation on the chat area. And Dr. Vipond and Dr. Hedges, you guys have some questions for Dr. Kraut, is that correct?
Yeah, I just wanted to, if I can go first, Kevin, because one of the questions I have is for you. I like Kevin's opinion on that last graph with the hierarchy of controls. Me personally, I think respirator mask is much better than anything other than perhaps elimination. I think of it like a anti-brake, anti-skid brakes on a car versus a seatbelt. Of those two things, what I'd rather work would be the anti-skid brakes. I'd rather not get in an accident rather than have the seatbelt save my life if I'm in an accident, mostly because I like my car and I don't want to pay for body work. So prevention's always better than dealing with the incident once it's happened. So that's why I'd rather not get the virus in my system and I have to rely on the vaccine, especially since the vaccines are not sterilizing. And there's lots of evidence that engineering cannot surpass PPE. We know that you can have a bunch of HEPA filters in a room, good ventilation, and you can still get infected because it's really about getting the virus in your system. If I'm talking close to somebody, I'm still at risk. And then I just have a couple other things I just want to mention. I like to hear both people's perspectives on this. When I hear about these protection, the use of masks, it seems all about me. How do I prevent myself getting infected? If I'm immunocompromised, maybe I should wear a mask. In the healthcare system, we're actually there to protect patients. And I think it should be them. One of the reasons why I wear a mask is not only to not get infected, but so that I don't pass on infection to my others. I actually had a colleague yesterday at work saying it's so ironic that the first day that I'm at work with no masking, I have a cold and I feel like crap. I'm coughing. I have rigors. He's wearing a surgical mask. He's going to be at risk of infecting his patients. And he's been told that that's okay. Thank God he's wearing a surgical mask because it's better than nothing.
Yeah.
Modeling shows that because of waning vaccines, the waning of immunity, as well as new variants, we're expected to get about 2 cases a year per person. Like generally in the population, we're expected to get COVID twice a year. So that means for a 10-day period, twice a year, the average healthcare worker is going to be exposing their patients to this disease. And when we talk about this hardship hassle, I think of construction workers who have the hassle of wearing a hard hat, the hassle of wearing steel-toed boots. The chance of them getting hit in the head with a brick every day is pretty low, but it's still an expectation of their work to wear that PPE even though it messes up their hair, even though it maybe makes them sweat. And so I just wanted to make those points. And Kevin, I'd love to hear your perspectives on those.
It's a really interesting discussion with the hierarchy of control, and I'll tell you why. There's work in the US at the moment. So the same, committee that's looking at respiratory protection in the US are looking at outward leakage. So looking at outward leakage of respirators, because we know that it's both inward and outward leakage that's important, especially if you're thinking about hospital-acquired infections. So controlling its source is very important. It's a bit like putting a filter on a diesel exhaust. You don't want to put diesel particulate matter out into the environment. So, but by putting a filter on the exhaust pipe, you're actually screening it. So it's not being released. So it's both important for personal protective equipment and also for the people around us. We don't want outward leakage. So the way OCA's kind of looked at this, we've kind of had this discussion, we've turned the hierarchy of control on its side. So all of these layers are very important. And if you look at the Canadian standard and you go through the control banding process, just because you have better ventilation doesn't mean that you shouldn't be wearing a respirator. If you have poor ventilation, suboptimal ventilation, then you might have to wear a powered air purifying respirator, but doesn't negate the need for a respirator, especially if you come in close contact with somebody. So in my opinion, Simon, I actually presenting for Simon because he wasn't going to make it, and now he seems that he's on the call. Dr. Simon Smith, that is. I don't think the hierarchy of control really applies to this situation, except in lower risks, perhaps, where there should be much more emphasis on the pathway. Engineering controls is something we've got control over. We can actually really improve our air quality, changing the air more often, having high efficiency filter, maybe in those lower risk settings, but definitely not in the higher risk settings. In hospital settings, no, we wouldn't take away respirators even if the ventilation is better. That's my opinion.
Yeah, no, I would
just
agree
wanted
with
to follow.
that.
Oh, sorry. Go ahead, Alan.
Yeah, no, I would agree. I think that for one has to use a number of layers to try to prevent this. I think that I'm not suggesting that we could improve the ventilation in our in the wards to the point where you don't need a respirator to deal with a COVID patient. But I do think that all of them together are important. So I'll take it that way.
Swiss cheese model.
That's right. You have to use them all. I appreciate Joe's point that it's important not to get infected. The reality is that we're probably going to get infected. I think that we should. I think that the vaccine will be important to reduce that. I think we're going to have a multi-pronged approach at this, and I'm hopefully we'll have to see what happens in the fall and whether we should bring back masking. I've started the discussion locally on that to see if we can, but not every people don't always listen to me on these points. So we'll see what happens over the summer into the fall. I know there's Joe, you mentioned about your concern about the hassle. The reality is that people have been PPE'd out, and there has to be, I guess there would have to be a change in mentality for us to accept this all the time. So
I know a lot of people who've left the profession, either nursing or physicians. I know none who have left because of PPE.
Yeah.
I know people who've left because they feel disrespected because the science is not being applied to their safety or to their patient safety, or the moral indignity of having to deal with people that were infected when they didn't need to be infected. I know of people who've quit because of long COVID. I honestly know of nobody who's quit because of PPE. I don't know. I could be unique in that.
Mm-hmm.
I know nobody in the construction world has said I'm quitting construction because I don't like wearing a hard hat. Sometimes we have to do things. And one of the things I think I want to reinforce too, and Kevin, you probably have something to say about this, is a lot of our staff has been fit tested to crappy breast cup style N95s, and they're horrible. I would be PPE fatigued if I had to wear a hard cup mask for 8 hours, and nobody should suffer that. But we actually have really good technology that's comfortable, that's breathable. They're working on even better breathability because we don't need the same rigor of respirator mask for a healthcare worker bioaerosols as we do for mining and pharmaceutical industry aerosols. So I think IPAC needs to reinforce and ensure that all staff are fitted to these soft fold, very breathable masks. They're actually are, well, for me anyways, they're more comfortable than a surgical mask. Kevin, you probably have something to say about that.
Yeah, just when we've been talking the bioaerosols group, comfort is such a huge factor. And with the innovation and the newer respirators being made, they're a lot more comfortable. And also the breathing resistance has kind of come down as well. So they're kind of almost the same level of breathing resistance as surgical masks. So, I'm thinking what we need to do is work on the culture. Surgical masks, they're accepted in hospitals. People generally wear them. Why not just replace them with respirators that are tested and approved? And you see that the Canadian standard specifications does actually allow ear loop respirators. So maybe ear loop respirators will get to a point where they'll be, the quantitative fit test pass will be the same as straps that go around the back of the head. But why not replace in those lower risk situations, where there's surgical masks being used, perhaps even KN95s, or the ear loop respirators will definitely provide much better protection than surgical masks. Just to think about the comfort level there too. Thanks.
And going back to I agree that for the most part, for people, the PPE that's being used right now works. So we know that surgical masks provide some protection, and two-way mask is much way better than one-way masking. So if the patient and the staff is wearing a surgical mask, you're relatively well protected. Unfortunately, what I see happening is that our infection protection and control are saying that that's evidence that what we're doing is working. And that's called survivorship bias, because they're looking at the whole population saying, look, we've only had 200 people who got infected in the last month from their PPE. I'm just making up a number there. What they really should be looking, instead of at the survivors and how that's worked for them, is looking at the failures. So of the people who got COVID at work, who suspect they got COVID at work, what were the failures that happened? And I can tell you just from experience, from colleagues, one of them had it because they were doing one-way masking because it was a child who refused to mask, who had asymptomatic COVID, and they had to do some suturing on the face. No wonder the surgical mask didn't work there. And then another one was a woman who was taking care of two very sick COVID patients who had high flow oxygen, not considered an AGMP, but both patients were very sick, breathing very fast, high flow oxygen in the same room. So these PCRAs that we talk about, in my experience in Alberta, none of the nursing staff have actually been given good PCRA, so patient care risk assessment. So patient care risk assessment, how sick is the patient with COVID? How much time are you spending in the room with the patient? Is the patient able to wear a mask? Do you have to be in close contact with that patient for a prolonged period of time? Are they actively coughing or screaming or agitated and causing trouble? That kind of PCRA has never been taught to our healthcare workers. And really, when you look at our PCRA, is there an AGMP or is there not an AGMP? Is there a suspicion of COVID? Is there not a suspicion of COVID? And everything basically funnels towards surgical masks unless you're an active COVID patient or there's an AGMP taking place. And that's just not safe.
Okay, thank you all of you for sharing all your point of views, how the PPE means, to anyone, not only in the healthcare right now. And then in the fact that, this schedule is scheduled to 11, now it's already 11, right? I know, all of the folks, have maybe have something planned, for afterwards. But we got a bunches of the questions we haven't been taking care of. how about maybe we could send it to 3 presenter, then we will try to answer it. And then I make a list and then the question and answer and send it back to all the participants. That would be saving people's time. And this session is already recorded. So, oh yeah, people ask, is the slide is able to share after that? Is your presentation slide is okay to share it out?
Yeah.
Okay, that's awesome. Thank you so much, for the presenters, Dr. Aaron Kraut, Dr. Joe Vipond, and Dr. Kevin Hedges. And then all of the participants here has been so participatory and engaging for sharing all the resources, conversation, and comment. We really appreciate you spending more than 1 hour and a half with us this morning. So yeah, we are going to wrap up this session right now, and then take good care of yourself, everyone, and then have a great summer. We'll see you soon. Bye, everyone.
Thanks for asking to present. Appreciate it.
Thank you.
Great presenter.
Nice meeting you, Joe and
Thank you.
Kevin.
Yeah.
Take care.
And you, Alan. Thanks, Kevin. Nice to see you again. Thanks, Tiffany, for inviting
We'll
us.
have to, we'll have
you.
to see what happens with in healthcare now that they've taken away the requirements. So we'll hopefully